It might take a little bit longer. Just kidding. Hi, everyone. Hi, everyone. I hope you had a great week and happy Friday. Today, my presentation will be on PPE, donning and doffing. So as you can see, it's presented by Vernette Malcolm, ICP student. First, what does PPE means? Personal protective equipment, commonly referred to as PPE, is equipment worn to minimize exposure to hazards that cause serious workplace injuries and illnesses. Meaning of donning and doffing. According to Fair Labor Standard Act, which was established in 1938 to establish workers' rights, the term donning and doffing is used to refer to the practice of putting on, which is donning, and taking off, which is doffing, protective gear, clothing, and uniforms. Personal protective equipment for infection control. Personal protective equipment refer to protective clothing, helmet, gloves, face shields, goggles, face mask, and or respirators, or other equipment designed to protect the wearer from injuries or the spread of infection or illness. PPE is commonly used in healthcare settings such as hospitals, doctor's office, and clinical labs. When used properly, PPE act as a barrier between infectious materials such as viral and bacterial contaminants and your skin, mouth, nose, or eyes through mucous membranes. Continue. Personal protective equipment for infection, continue. The barriers have the potential to block transmission of contaminants from blood, body fluids, or respiratory secretions. PPE may also protect patients who are at high risk for contracting infections through a surgical procedure or who have a medical condition such as an immunodeficiency from being exposed to substances or potentially infectious material brought in by visitors and healthcare workers. When used properly and with other infection control practices such as hand washing, using alcohol-based hand sanitizers, and covering coughs and sneezes, it minimizes the spread of infection from one person to another. We continue with personal protective equipment for infection control. Effective use of PPE includes properly removing and disposing of contaminated PPE to prevent exposing both the wearer and other people to infection. When an infection outbreak affects a broad population in the United States, the Center for Disease Control and Prevention is responsible for making specific recommendations for infection control measures in different circumstances and settings. For example, the CDC has provided the following recommendations. So these are just some links of what you should know about the flu and what you should know about Ebola. The FDA's role in regulated PPE. I know we're in Canada, but I put a little bit of the US in the slides also. All personal protective equipment that is intended for use as a medical device must follow the FDA regulation and should meet applicable voluntary consensus standard for protection. This includes surgical masks, N95 respirators, medical gloves, and gowns. The consensus standard and the FDA's requirement varies depending on the specific type of PPE. When these standards and regulations are followed, they provide reasonable assurance that the device is safe and effective. Some PPE are reviewed by the FDA before they can legally sold in the United States. In this review, known as pre-market notification of 5(1)K clearance, the manufacturer have to show that they meet specific criteria for performance, labeling, and intended use to demonstrate substantial equivalence. One way substantial equivalent may be demonstrated in part is by conforming to the consensus standard for the barrier performance and resistance to tears and snags. Voluntary consensus standards may also be used to demonstrate sterility when applicable, biocompatibility, fluid resistance, and flammability. Manufacturers must validate the method used to test conformance to standard and support each product with appropriate performance test data. For additional information on FDA role in regulation specific PPE, please go to a few links are here. I want to talk about some myths versus facts about PPE. Personal protective equipment is key to infection prevention and control. I want to help address some common questions and misconceptions about PPE, so you have clarity on how to use the proper protection. Gloves. These are some of the common questions that are asked. Should I sanitize or wash my gloves? I would say unwashing must not be done with gloves on. The purpose of gloves is to create a physical barrier between your hands and anything you come in contact with. Gloves are not a perfect barrier, so you must also practice proper hand hygiene when putting them on and taking them off to ensure your hands are sanitized. Sanitize your hand with alcohol for 20 seconds or wash your hands with soap and water, scrubbing for at least 20 seconds, making sure no areas are missed to ensure your hands are free of contaminants. These are some missed areas when performing hand hygiene. The brighter purple is most frequently missed. The lighter purple is frequently missed, and the less frequently missed are the brown section. Myths and facts continue. Gowns. Can I wash my disposable gowns? No, no, no. Disposable gowns are used to protect your clothes against contaminants. Washing gowns might damage the material and it's not recommended. What are level 1 gowns? There are 4 levels of risk and gowns classification. Level 1 gowns are used as a precaution and for simple procedures, such as during basic care, isolation areas, cover gowns for visitors, or in a standard medical unit. This slide is just showing a few of the levels of gowns. Level 1, minimal, standard precautions, simple procedure. Level 2, low, minimally invasive surgery. High risk, level 3, moderate, open gastrointestinal surgeries. And level 4, high, open cardiovascular procedures or trauma procedures. Myths and facts continue. Should I use 2 masks for more protection? There is no evidence that double masking provide any further protection against droplets. When is it required to use N95 mask? N95 masks are required for prevention against airborne infections, including tuberculosis, chickenpox, measles, and disseminated shingles. They are also required when aerosol-generating medical procedures are being performed for COVID-19 cases such as open airway suctioning, non-invasive positive pressure ventilation for acute respiratory failure such as CPAP and BiPAP, high-flow, did I do that? Sorry. High-flow oxygen therapy, 15 liters per minute. For additional resources about PPE, please visit Public Health Ontario, PPE donning and doffing. A recommended step for putting on personal protective equipment by the Public Health Ontario. First, perform hand hygiene. Put on gowns, tie neck and waist tie securely. Put on mask or N95 respirator. Place mask over nose and under chin. Secure tie loops or straps. Mold metal piece to your nose bridge for respirators. Perform a seal check. Put on protective eyewear. Put on eye protection and adjust to fit. Face shield should fit over brow. Put on gloves. Put on gloves, taking care not to tear or puncture gloves. If a gown is worn, the gloves fit over the gown cuffs. So this is just a picture of what can be posted in facilities for staff to see how to do it. So I just explained the whole performance from 1 to 5. Recommended step for taking off PPEs: remove gloves. Remove gloves using a glove-to-glove, skin-to-skin technique. Grasp outside edge near the wrist and peel away. Roll in the gloves inside out. Reach under the second glove and peel away. Discard immediately into waste receptacle. Remove gown. Remove gown in a manner that prevents contamination of clothing or skin. Starting with waist tie, then necktie. Pull the gown forwards for the necktie and roll it so that the contaminated outside of the gown is to the inside. Roll off the arms into a bundle, then discard immediately in the manner that minimizes disturbance. Perform hand hygiene, remove eye protection. Arms of goggles and headband of face shield are considered to be clean and may be touched with hands. The front of goggles face shield is considered to be contaminated. Remove eye protection by handling hair loops, side or back only. Discard into waste receptacle or into appropriate container to be sent for reprocessing. Personally owned eyewear may be cleaned by the individual after use. Remove mask or N95 respirator. Tie ear loops. Straps are considered clean and may be touched with hands. The front of the mask respirator is considered to be contaminated. Untie bottom tie, then top tie, or grass strap or ear loops. Pull forward of the head, bending forward to allow mask respirator to fall away from the face. Discard immediately into waste receptacle. Perform hand hygiene. And this is a little picture of postage for taking off from step 1 to step 6. Recommended step. These are just some link from Public Health Ontario of videos that I can't show because we don't have the time. So these are just videos that they can show how PPEs are done in and doffing. Summary of recent changes from CDC. As of June 9th, 2020, the CDC adds some recent changes regarding PPE. Add a statement about the importance of the selected respirator and eye protection not interfering with the correct fit or function of the other. They have removed a second hand hygiene step from the step 6 in how to put on and don PPE gear. Who needs PPE? Check circle solid icon. Patient with confirmed or possible SARS-CoV-2 infection should wear a face mask when being evaluated medically. Check circle solid icon. Healthcare professionals should adhere to standard and transmission-based precaution when caring for patients with SARS-CoV-2 infection. Recommended PPE is described in the infection control guide, and there is a link also. And these are some references regarding PPE, equipment infection control, and other ways to deal with that. And these are some more references from Public Health Ontario with videos and other information. Thank you, thank you, thank you. Questions? Any questions?
Well, congratulations, you made it.
Yes, I did.
Congratulations. It's hard to go first. So I'm gonna take over if I can. See if I can do that. All right, I think I made it. Anyone has any questions for Vernette or anything with regards to the presentation?
Thank you. I see. Well done. Great job. Thank you guys for listening. First is always the hardest, but it's okay.
I know. So I just want to make sure that everyone is aware of the time. So Vernette is going in front of me, so we have a little bit of flexibility given we have entire class here. But when it comes your time to present, just be cognizant of your colleagues who are following after you, because we have to do this exchange and everyone is nervous and we only have so much time. There's so many of you that will be presenting, and once we start bumping people, it just creates a lot of chaos. So just stick to your 10 minutes. We do have, as I said, I put in 5 minutes on the end of your presentation as a buffer to allow for that exchange, but just be cognizant of your colleagues' time. All right. So as you guys are going through, I will be marking your presentations. I think you will be able to see the marks in your under your profile, so you will see how did you do. I got a notification that in my email that Vernette is supposed to present and I should show up. All right.
That's funny.
I know, right? Go. Vernette is presenting. You better show up for that class. Okay. So tomorrow at 10:30, we are gonna start with another group. So we are gonna have 12 presenters tomorrow morning. And so if you're not presenting and you can join, please do so. I think it's nice to hear your colleagues present. It's also supportive, but I think it's also a good refresher for all of us to go through this. So tonight we are gonna go and cover Outbreak. So let me see if I can share my camera, or am I gonna crash again? Okay. So I just noticed, I wanted to point out something. So I don't want you guys to stress if something goes wrong on these screens. Last week there's like my slides were doubled up for some reason. I noticed also Vernette's presentation, some things shifted over, where in her real presentation that didn't happen. So just don't stress. If you see something like that, just carry on. I see your original documents. I know how they look, and I open them on my screen and follow just for that purpose, to see how does this actually look when you are presenting. Okay. So you guys ready to learn about the outbreaks? This is going to be a big chunk on your CIC exam. I think it's about 12 or 13 questions is in some relation to outbreaks. So here we go. Fun times. Just in case you didn't have any knowledge about outbreaks before. Like that's like a really smooth shift between you and I here. So we are gonna cover some of the the topics that you know, but I'm sure there's going to be some of discussion that you may not be as familiar. And as Vernette did, to focus on the information from the states, we carry on focusing predominantly on the information from the states, from APIC book. But if there is something that is different, I will highlight that for you as we go through. But we will learn about how to identify the outbreaks, how to manage the outbreaks, what we need to do to plan, and also we'll touch a little bit on pandemics and bioterrorism. Bioterrorism is apparently going to be a big chunk. So as I spoken to some people who have taken the exam in past weeks, they seem to notice increasing questions in relation to bioterrorism. I cannot remember if I had maybe one or two questions back in when I was taking my exam, but here we go. We have to focus. All right, let's take off. So for all of you, a little bit of a history. I kind of always like to look at how did we do in the past and kind of compare and contrast to see whether we are actually showing any signs of improvement or not. But the image actually represents the doctor, the PPE. This is nicely fitting right after Vernette. But it was PPE they wore in the time of plague. And so this beak was actually filled with some fragrant plants to mask the stench of rotting flesh that was on the streets. So I think things have slightly changed for us, but maybe not so much. There's still PPE we are wearing. It kind of resembles beaks. Still, we cover our eyes. So he knew what to do, but he was also a gentleman. Therefore, he had a hat as well. So back in the 441, we had the plague, and plague seemed to be, you will see, it seems to be one of those outbreaks that does take out numbers of people, and it's expected, it's actually anticipated or calculated, I should say, that took out about 30 to 50 million people back then. And the next one, big one that was documented and reported was the Black Death in 1346. That one took about between 75 and 200 million lives. So it's interesting to see, that we had ability to track and document lives lost even from the olden times. So we should do much better nowadays when we have all the electronic devices and everything else. So we should be able to document better, right? One would think. So I'm just writing myself a note to post something for you as I'm going through this. Okay, so then we see there was so these cholera pandemics, they were actually numbered. So there was like a first and second and sixth. So the third cholera pandemic actually has taken about 1 million lives. And you see it was in the period of 1852 to 1860. So it's interesting how some of these numbers are up and down, and how I think the impression and understanding of risk will change as you kind of come closer to current state, and you see the numbers and the perception of how certain things affect us change significantly. Then we had our flu pandemic in 1800s, and that one actually took about 1 million lives. And then, of course, the sixth cholera pandemic in 1899, it was accounted for about 800,000 lives lost. So the big one that everyone talks about, and I think has been quite a lot in the media with COVID, is the flu pandemic or Spanish flu that was attributed, actually the end of the First World War was attributed to the flu, because it took out so many lives. It took about 100 million people's lives aside of the war that was raging through Europe, but this was on top of it. So there was no people anymore to go to war. One way or the other, we find a way to finish it, but probably would be better we didn't start it at all. Anyway, the following would be your Asian flu, and then closely followed by your Hong Kong flu pandemic. So they're all about like millions. There's quite a lot of lives that these outbreaks take out, the large epidemics of the human existence. And then we are kind of coming closer to modern times, and we have the HIV pandemic, which is probably one that has taken in the modern time the highest number of lives. If you look at it, it's about 32 million lives lost due to HIV. Then, of course, we have SARS, and SARS was something that was spoken so much about, yet 774 lives documented. Not to say that the number should be higher for us to talk about things, but just on the scale of things, it's interesting how certain things get the media attention versus the others. Then we, of course, had our swine flu in 2009. So that was about 151,000. And look at that estimation, how widely ranged that is. And why is that, one would ask? It comes back to that reporting and the quality of reporting and quality of surveillance. So if you remember that iceberg that I was showing to you guys, so with flus, people often don't go to see their physicians unless they're really, really sick. And then also the recognition of these of the diseases, in particular with flu. So you have to have, when you're reporting it, it has to be laboratory confirmed. And in communities, we tend not to swab our patients as much as we do that in long-term care facilities and acute care facilities. So that's where the such a large gap in the numbers is. It's just an estimation what we are looking at. Of course, then we have MERS, which it's also, again, it's very interesting. I don't find that a lot of people talk about it unless we are in the IPAC world or we know someone who has been impacted by it. That's not something that's been widely discussed in the media or the general public. I wouldn't say they're quite that much aware of it. So we have Ebola after that, of course. Ebola was another big topic in recent years. I think it has to do, when it comes to coverage of certain diseases, it also has to do with the outcomes and how certain diseases present. So of course, with Ebola being a hemorrhagic fever, it does come with a little bit of bleeding that does actually affect a lot of interesting discussions in the media, more than actually the way and who is affected. So which, for better or for worse, I think we have ramping up in preparation for Ebola here. We have done a lot, and I would say, I keep saying this, more than necessary, on a scale of a risk and on a scale of a true possibility of being affected here. We done a lot of money spending in training, buying PPE, and I think it was a bit overkill in my opinion. I think, but I think most of IPAC practitioners will agree on this, that was just a little bit too much, and it was more a response to I would say more in a political way than actually scientific way, if that makes sense. Zika, of course, Zika has been around for a really, really long time, but it it's quite common occurring in European countries. However, the mortality rate in Mediterranean countries is not as high, and it's never been really discussed to the same way until it got here on the American continent, and it started picking up. And it has to do with previous exposures. So people here haven't had much exposure to it, therefore the outcomes and consequences were drastic, and it does have mortality among the children, and it's the congenital malformation. So again, it has to do with the perception of risk versus versus the actual numbers. So if you're looking at Zika, mortality was estimated about 1.5 cases. Not even sure how they landed up with 1.5 cases, but there we go. And it covers only the mortality rates. It's interesting actually how it's broken down. It's impossible to actually land on any particular numbers across coming from either CDC or the World Health Organization sharing that information on a global level. So it's broken down by endemic areas, it's broken down by different parameters, but nothing that you can actually collate easily. So you have to spend a lot of time in gathering information. And for these purposes, I really didn't want to spend so much time digging and breaking down and comparing apples to apples through their statistics. So it was just a little bit nutty. And of course, you guys know with COVID, I made this presentation couple of weeks back. I'm sure these numbers are higher now, but it's about 4 million is actually that is the death toll, and it's about 190 documented millions of affected individuals across the world. So I think this would be probably the most accurate and reliable information that we have in such high numbers that we have in recent years that we dealt with. If you're looking at the previous years and centuries when this information was collected, I think this is probably going to be one of the best assessed epidemics in history. So here's a couple of things that I want you to take a note of and just think about memorizing this. You may be asked about some of these definitions as a part of a larger question. You will not be asked to identify these definitions and pick one or the other, but you will have this, it will be woven into your question. So just know what they are. So of course, your case definition, a set of uniformly applied criteria. Clusters, you guys know, you talk about clusters at work all the time. So clusters are number of cases that are grouped by time and place and may be greater than expected numbers. So this is something that we would be looking at before we declare an outbreak. Colonizations, and I actually have been going through some of your questions in your exam, and this is something that I actually wanted to highlight to you. Colonization is a presence and growth of multiplication of microorganism in a host or on a host if you want, but without clinical response. So scabies, lice, that's not a colonization. So anything like MRSA, VRE that does live on us, like Staph aureus that lives on our skin, but it does not cause any harm, that's colonization. Common source, of course, it's usually when we are looking in terms of outbreak transmission. So it could be either intermittent or continuous. And then control measures are the measures that we usually put in place to interrupt or reduce or eliminate the occurrences of communicable diseases. So we often refer to them in our day-to-day work in terms of enhanced cleaning, auditing, improving on hand hygiene, auditing the PPE usage, and so on and so forth. So those would be some of the terms that you will need to know and be able to answer your questions properly. And a couple other things I wanted to mention is also cohorting. That also is a part of your control measure. So I think with COVID, all of you had heard of some type of cohorting. Whether we are cohorting patients, you can also cohort staff. So usually we do that during outbreaks to help with the workload, also reduce the transmission and mixing of populations. Environmental sampling is something that we do when we kind of really struggle finding the source. Usually environmental sampling is quite often related to waterborne diseases, if you're looking into, say, Legionellas, or if you're looking into um, any sort of environmental contaminants. So you could be collecting air specimens as well if you're looking into air quality, if you're looking for asbestos or aspergillus, or if you're looking for potentially something being spread through your unit through the HVAC system. Environmental sampling is not something we would normally do. It's kind of extreme for us. When you have MRSA outbreaks or VRE outbreaks, that's not our go-to, right? So usually we are looking into human specimens first. And then when you're looking into potentially looking at some of the contaminants that may be linked to poor hygiene or poor cleaning practices, that's when you may start looking for collecting environmental specimens, say for a VRE outbreaks. But MRSA is usually not something we would do. TB, definitely not. What else I wanted to highlight for you? Measles as well. So those are not diseases that are spread and contracted via fomites. So we wouldn't be collecting environmental specimens for that type of outbreak. Epidemic curve, you guys know what they are. I'm sure you have produced some. If you haven't, you've seen them. Those are your histograms. Usually you can summarize your outbreaks, or you can use them in your surveillance processes. So quite frequently you will find them and especially now, I would say quite frequently you will find them in use to identify the number of COVID cases. You will see that they're using these histograms also to identify the number of vaccinated people, for example. So that's one way of presenting information. Line list, everybody knows. We've been through this many a times. It's the document that contains all information about your affected population in an outbreak. So you start with the names, the patient's medical record numbers, and then you have some of those additional demographics like sex, age, or date of birth. And then as you're kind of working your way through it, you have somewhere in there built in your case definition symptomatology. So you have, depending on what are we looking at. So if it's flu, you would have fever, shortness of breath, cough, sore throats, and all of those symptoms. So you go and work through that. Symptoms in your line list, and then you may add at the back also some contributing factors or some information of interest. So some of them would be also following the movement of your patients, like where they were before, have they been admitted to another healthcare facility. Also, you would have the date of recovery or the date of if they passed, and then also whether it's a coroner's case or not. So you can have a different category. You can have different categories in your line list suiting your needs and responding to what you're looking for. But you always have to have the demographic piece, and you always have to have the symptoms in there. And of course, outbreak. So I think what's important for you guys to know that there is some outbreaks that are clearly defined, and we do have definitions for them. So some of these are preset. However, for outbreaks like MRSAs or VREs, especially when we're speaking about the colonizations, you're looking at the increase of the occurrences. So you have to calculate your baseline, and then you're looking at these standard deviations, and how many standard deviations away from the mean you are when you're calculating them. So usually we are looking at anything that is more than 2 standard deviation that would be definitely something we would consider to be an outbreak in these cases. Okay. Okay, so a little bit of course, your background. What are the outbreaks? So usually we are referring to outbreaks in healthcare settings, of course. You may refer to outbreaks also in general population. However, we tend to call them epidemics when they're outside of the healthcare facilities. So when you're talking about these outbreaks in your healthcare facilities, you always start with identifying your healthcare associated infections. So when you look at them, they obviously have to meet the case definition for a healthcare associated infection. So you're looking at a couple of things that may affect that outcome. So whether there is exposure to patients with suspected or confirmed communicable disease. So how do you determine something is a healthcare associated, right? So you're looking at where did this come from? Did this patient come through the doors with it, or did they come in and then because of the factors that were not followed fully, now we have a healthcare associated case? It can be linked to improper spacing, improper placing of your patient, could be inappropriate use of PPE or lack of PPE, inappropriate hand hygiene, could be that you're looking into placement with colonized or infected, assignment, I would probably say better, assignment to either infected or colonized healthcare providers. So if, say, Sharon came in and she was just like dripping out of her respiratory system and she went to provide care to Vernette, that would still be considered a healthcare associated case, not necessarily in a transmission patient to patient, but Sharon has come to work sick. Against all the better knowledge she has, she decided to come in and take care of Vernette and say, I'm so sorry, I don't feel so well, but let me drip on you. Okay. So a couple other things that also you can put your patients at risk is using, of course, contaminated devices or products. So you could be something that we have contaminated at the point of care or in our healthcare by using like stethoscopes or commodes and so on and so forth. But there is also a possibility that something comes contaminated from the manufacturers. So I have actually shared here a link with you if you're interested to take a look. But there was a time, couple of years back, when we had these wipes that are quite commonly used actually in healthcare. So they have two kind of lines of wipes, this particular manufacturer, and so they have the ones that are impregnated with chlorhexidine and then just regular wipes. And what happened is we suddenly started seeing that patients are getting testing positive here, and further investigation actually got back to this particular wipes. Of course, no one knew, and then the entire factory closed down. They recalled all the wipes. and they recalled more than just affected wipes and started from scratch. So something to also keep in mind, that could be something that is not necessarily we are generating or creating in our facility, of course. And we always forget about these visitors. I think as of recent with COVID, not so much, but in the past we would had quite a lot of visitors, and they tend to provide care to their families, to their loved ones. I've seen situations where they, out of their kindness, they will help the roommates as well. Something that is just cringeworthy to us as IPAC. You don't really see the kindness. All you can see is like, my goodness, what are we spreading here? But yeah, some people don't understand the risks that are involved with just passing a blanket or a water to someone. All right, so now we get into what and how do we manage these clusters, and how do we identify them, and what happens once we have identified the clusters or outbreaks. So what is really important for us to know is that all our facilities must, there is no ifs and buts, we must have resources to manage the outbreaks. And even when we look into COVID and in retrospective, what has happened in past few months or past almost 2 years, we notice where the gaps are. But regardless, there was every facility had some resources to manage the outbreak. Some of these outbreaks got completely out of control, and they were on such a large scale that would be impossible if they had 20 IPAC practitioners to manage what was going on. So I think it's important to recognize that we all have to have the means and staffing to manage the outbreaks, but sometimes we just cannot based on the scale of, so some of these things are out of our control. We are mandated to have programs and to ensure there is capacity to operate at the levels without outbreaks, but also to include those hours that come in management of outbreaks. So you should have some lull time for your staff, and you're planning for staffing outside of the outbreak times. So usually, of course, the senior leadership doesn't really like to have a lot of people lingering around, but this is the time when we do actually other things and improve on the programs and write papers. And if you ever are in a position that you work in a facility that does employ sufficient number of practitioners, and outside of outbreak situations, you know that there is always some time to do some additional projects and do some cool things that IPAC does as well, not just surveillance until we are blue in the face. So once we have established that there is, I guess, a problem, what we are looking at is looking back into information that we have collected. So we continuously should be collecting information in terms of baselines. So we need to know what is the status across the facility, broken down by the units in terms of are we looking at MRSA? Are we looking into flu? Are we looking in VRE, and so on and so forth? So you are able to actually go back and say, even if you see the increase, so you can do those calculations and establish determine whether there is a true increase in numbers, true calculations, and being able to say, okay, now we have an outbreak, here is the numbers, we have historical data that presents, now we have a blip. Sometimes it's really easy for us to see, even without the calculations, suddenly you have 10 people on your unit with diarrhea and vomiting, and a week ago there was none, and they're all your long-term stay patients. You have a problem. You know that right away without calculating your rates. So that's kind of how that works. Also, what's really important for us as practitioners is to actually be able to report the number. So I think it's critical for us to communicate whether there is a problem and how do we communicate that information. So I think if you can kind of look at in quickly extract that, that's really, really beneficial for everyone. I know usually when you have something going on and you come to work and suddenly you'll have these positive results, the managers are coming in and asking, are we in a problem? What's going on? What was the number last week, last month? Where are we? What's happening here? So you can quickly produce that. Often they want to present that to their own directors, to their own leadership, and explain what's going on. I think for us, as in IPAC, we are dependent, very, very dependent on our micro reports. And I think it's what is really important, if you can establish and create a really good working relationship with your lab. So even before things get pushed out electronically, if they see something trending on their benches and they're seeing these preliminary results coming through, they can give you a call and say, you know what, something's going on, get ready. We may end up with having so many problems, so many positive results. So usually that's how that works. If you establish a really close working relationship, so you want that heads up too. And I know Vernette likes to get heads up before things hit the fan. She told me that. All right, so here is some headings from the news in terms of number of different outbreaks, and I thought this would be interesting for us to just kind of take a look at how many people do get affected by the outbreak. So there is the 9 people that died in London, Ontario as a result of your group A strep outbreak. And then norovirus, I know Kyle will be teaching us a little bit more tomorrow about the norovirus, but they tend to be really interesting outbreaks to take a look at if you're ever interested. And it's kind of cool because it's contained is on the ships. So people actually don't go anywhere. No one comes to them. They're just locked up on a ship and cruising on the sea, and suddenly you have an outbreak. So it's kind of cool to review those outbreaks. I will put up some for you if you're interested to read. Just writing myself a note because I'm getting old and I keep forgetting things, and I don't want to forget things that I promise you. Okay. And then of course you guys know, if you ever Google out word outbreak, for next 5 pages is going to be only COVID. So you have to be more specific with Googling your outbreaks, what you're looking for. So what are the HAI clusters or HAIs? So with healthcare associated infections, you always have to go back and refer to the case definitions. And when we talk about these clusters and outbreaks, they're always looking into the healthcare associated cases. We are not looking into whatever came through the door as a community. Could it be something that came from another facility? So we always look at our own cases. So it's critical for us to establish that this is a true healthcare associated case. So we are not creating chaos in our own facility by mistakenly attributing a case to us where it's not ours. It is important that we are prompt on handling these cases, that we put the early interventions in place to prevent further spread, of course. But it's also important that we are careful when we are assessing whether something is our case or not. So just receiving a positive result, it's not enough. We always have to look at the history. Where was this patient? How long have they been with us? Have they had previous admissions? So I think it's equally important to look. So say, for example, I'm going to just use an example of C. diff here. So if your patient is not meeting that definition of healthcare associated case because they have come through our doors with diarrhea and now they're positive for C. diff, and it's quick to say, oh, this is not our case, they just came with diarrhea. It's important to look back and see if they had previous admission to our facility to identify if they're actually meeting that second part of the case definition. So just always stay on top of. And a piece of advice for you, I always had my case definitions printed, and then I would cut these little snippets and put them on my desk, so I would know to quickly, kind of just as the result comes in, I would peek over to look, what am I supposed to look at? And it's kind of just keeping you on top of it. It eventually becomes a second nature to all of us to kind of go through those critical points, critical assessments, checkpoints, or whichever you want to call them, check boxes. But when you are new in the field, you kind of want to those reminders. So I had everything plastered behind my computer desk and always looking like, what's the case definition for C. diff? What's the case definition for flu? So it's kind of cool to have that if you can kind of use anything to help you along. I also used the sticky notes, and there are sticky notes on your computer, so you can have as many as you want and just pull them up. And if you're not a paper person, that also works. So there are a couple of things that you can use to remind yourself. So that's kind of what I do. There's different tools, I'm sure, from one facility to the other that you can ask your colleagues to help you along. Also, when we are looking into these management of HAIs or clusters, if you find yourself that you kind of a single person fighting something, you can always reach out to your public health units. You can ask your neighboring facilities. You can call a hospital next door, or you can call Public Health Ontario and ask them to help you with some of these questions. And they're always very happy to do so. I know through COVID in particular, there was a lot of lending expertise between the facilities to support each other. Your regional infection control networks, they kind of have collapsed somewhat. There used to be 15 offices across Ontario. This is only for Ontario. For you guys who are outside of Ontario, you don't have RICINs, and I don't think, and you definitely never had them, but we also have lost significant support from the RICINs in terms of availability across. So I think they're down now to 5 offices, if I'm correct. Yeah, so you're right, Anika. We always go back. You know what? It's just, I find like with some of these things, if you are not doing it every day and you're ears deep into it, you forget, and sometimes you start questioning yourself too, and it's there. So no one's gonna fail you on exam if you're looking at these PIDAC documents. We all do. So I know every time I look at something, I refer back to just to make sure it's all clear in my own head. And some of their recommendations are so clearly laid out that is really cool, easy to follow through what the expectations are from us. No, PIDAC has so many great resources. It's really a leading program in, I would say, in the world of infection control. I will just say, for example, the Just Clean Your Hands program that is developed by PIDAC and by Public Health Ontario, it has been adopted across the globe. So of course people adopt and adapt and change, but it's definitely a high quality information. It's very simple to follow. So I highly recommend everyone, even if you're not in working right now in IPAC field and you're kind of looking into this to something to be your future, definitely look at these documents. They're really helpful. They have everything from AROs, respiratory diseases, C. diff, to reprocessing in community. So everything is in there. So there is, yeah. Yeah, so Just Clean Your Hands is no longer actually residing. The responsibility is no longer residing with Public Health Ontario. So they downloaded that program as a full program to the local health units here in Ontario. So it kind of shifted the ownership. Still a lot of resources available through Public Health Ontario. You can't order, unfortunately, any of those free resources anymore through them. Years back, you could order handouts and posters and those little cards that they would have, like the auditing tools that you would give to people when you're auditing them. The on-the-spot feedback is what it's called. So none of that is anymore, sadly, available to us, but it was really good when it was there. So sorry, I'm taking you on a journey in the past to what's not there. So when we do our outbreak investigations, again, taking you back to the triad of agent and host and environment. Always revolve around that. All your outbreaks are always in relation to an agent, which could be either a virus, a bacteria, or parasite. Your host, in our case, we always talk about humans. If you work in veterinary sciences, you would be talking about cats or dogs or some other animal for that matter. And then, of course, the environment. So it refers always to the environment that surrounds the host and the agent. So that's how you're looking into all of your outbreaks. When you start managing or investigating, you always have to have these three lined up. The goal of our investigation is to control the outbreaks, of course. And then when you get to a point that you're investigating your outbreaks, you're looking into identifying and modifying contributing factors. So what can be done? So this kind of best explained and seen through the chain of transmission. So if you're looking at all your links in a chain, which one is that you can adjust or manipulate in such fashion to break that chain of transmission and stop further spread, which would in the end slow down and hopefully eliminate and stop your outbreak from going on. So epidemics or outbreaks, it's a same term, it's the same definition, it's just a different place. We tend, as I said, to refer to them inside of the healthcare facilities as outbreaks. They tend to be less scary, I guess, than epidemic. But if anyone has ever said the word outbreak in front of other people, you know that it's not less scary. All those big eyes suddenly just pop at you when you mention it. What is really important about investigating our outbreaks is that you may end up with smaller scale outbreaks. Regardless, doesn't matter how big or small they are, we always are responsible to report them to our local public health unit. So we do communicate, of course, internally, but these guys are our liaisons and our partners in crime and help us along, but we also have an obligation to report to them. When it comes to contaminated or defective products, if you had something to deal with that came in from outside. So say sometimes like if you're working in a facility that does deal with surgeries, or wherever there is a blood transfusion or human tissues, and if those are coming in with potential hazards, you definitely want to communicate this further out than just your local public health unit. So depending on, of course, whether we are talking about Canadians or talking about Americans, in Canada, we report to our Canadian Food Inspection Agency, to the Ministry and Public Health Agency of Canada, depending on what are we dealing with, of course. And then, of course, in the States, they deal with FDA and CDC. One of the steps is identifying our population at risk. So when you are managing or looking at your outbreaks, you're also looking at who else is at risk to get exposed and actually end up with this particular disease that we are dealing with, whatever it is. So you always want to look at your population at risk. It could be anybody on your unit, could be only certain populations. So if you're talking respiratory diseases or MRSA or VRE, so it's everybody on your unit. However, if you're talking about potentially any sort of contamination through either surgical procedures or your ventilator-associated pneumonias that may be linked to a common organism, you're looking at a very specific population. So you wouldn't be affecting everybody on your unit, just these people that have underwent these particular procedures. Us as practitioners, we absolutely must know in and out the microbiology piece of the microorganism. So we have to understand the basic principles of microbiology. We have to understand the modes of transmission. We have to know the incubation periods. We have to know how to manage these diseases in order to prevent them from happening. But we also have to understand a little bit of this human interactions with these organisms in terms of directing our colleagues in right direction, so to speak. So if you're having someone who has either a professional exposure to blood, you know that you shouldn't say, oh, it's okay, don't worry about it. You would be sending them to see the occupational health because they may need that post-exposure prophylaxis. It's not something we get involved with prescribing. However, we have to understand how this needs to be managed, these exposures, because I find for us as IPAC practitioners, we often get asked these questions because we are so frequently available on the unit. So our colleagues see us and they come to us. And that's for better, not for worse. We always want to be that, that friendly face that they can turn to. Am I losing you guys? What's happening there? Is everyone aware where we? Anyone needs to go take a break? Let me know, and then we can maybe take a 5-minute break. Okay. Burnett is all pumped up. She's like, I'm ready to go. Okay, so when CDC actually addresses these outbreak investigations, hello. Someone arrived, I see that. There is a very specific set of steps, so to speak, for them. So they always want you to go through these check boxes or steps, I think would be the best. So confirm the presence of an outbreak. That is your first step. Doesn't matter whether you're in the States or in Canada or anywhere in the world. We always want to make sure we do truly deal with an outbreak. So to do so, you always have to look back to that HAI. So I think in most cases, you would know you have at least one case, and then you would be investigating going backwards, but also moving forward. So once you have a new case, you want to kind of have a high alert and look for new onset of symptoms if you're talking about syndromic surveillance. But you also want to go back. So this is important why we need to know the incubation periods for certain organisms, because you can go back and take a look if we missed accidentally something in the past and something went underdiagnosed. So you can go back and take a look at those cases as well. When we are verifying diagnosis, this is not something that is done solely by IPAC. So usually for us is we go back, review the patient chart, take a look at diagnosis. So you will have something as admitting diagnosis, and there is something like a working diagnosis. So usually when your patients present in emerge, so this is for acute care settings I'm speaking, usually there is an assumed diagnosis based on the symptoms they're presenting. At a later date, you will find that that diagnosis will change if different diagnosis is set. So we want to make sure we actually don't look just when you open your patient chart, you don't look just at that top piece, whether it's electronic chart or front, if it's a paper chart. You have to take a deeper dive and see what the physicians actually have agreed on and landed on. So that's where you're looking for these diagnoses. Often in electronic charting, when you open a bunch of patient charts, you will see only that admitting diagnosis that's been documented in emerge. Depending on your electronic systems, the change may be reflected right there, and you may see that in some electronic systems that will carry on through, but you have to take a deeper dive in a chart to find that diagnosis. Of course, you're looking into laboratory confirmation, and if you're unclear, always have a discussion with the physician. So your case definitions are, as I said, listed in documents. However, for the outbreak purposes, you are always talking to your team and your public health unit to establish that case definition. So as I mentioned this in past to you, this may slightly be different from the set definitions. Ideally, you don't want to vary too far from set case definitions that are provided to us by various government agencies, so stick to them as much as you can. Sometimes, as I said, you can't, you have to change. Make a note of that. Next step is, of course, is alerting administration and talking to your healthcare partners. This would be your unit managers, your unit directors, senior leadership. You also want to take a look at your literature reviews and what's happening in the community. I think with some of diseases, we are quite comfortable without actually diving and dissecting every piece of information. It's good to do a review to see what's new, what's trending in terms of management and recommendations, to see how other people are doing. And as I said, it's something that we often sadly don't have enough time, but back to PIDAC, always go back and look at those type of documents. You just can't work without reviewing your case definitions. You can't work without reviewing the recommendations in terms of management. What are they recommending for isolation, duration of isolation? You have to refer back to these type of documents. Also, when we are looking into case finding, this is usually done done in communication with your team and your managers and your infectious diseases physicians. Usually you kind of decide on what are we going to do. We're doing a point prevalence. How frequently are we going to do these point prevalences? Who is going to be screened for these purposes? Are we screening only the roommates? Are we screening the entire ward? Are we screening everybody that has been on that unit? So you kind of have to work out with your team what, in depending on what is that you're looking for, who is your population at risk. So sometimes I would say probably for most of you would be easy to relate in case of MRSA. So you have an MRSA on your unit, and now you know that this patient hasn't been isolated because whether we didn't screen them or they were negative maybe when we screened them previously. So now they're positive. So you have to kind of trace back, where were you, what happened, where was this patient, who are their roommates, how much time did they spend. So you will find that in some facilities, they will have different categories for these exposures. So they may have something either called a roommate or a contact. So for these facilities, the decision to do so is space limitations usually, and they're looking in reducing the number of isolating people. So they will still screen everyone, but they may not isolate everyone because they simply don't have a number of private rooms, and those are some educated decisions that they made. So usually the cutoff is anywhere between 48 to 72 hours. This is not written in stone. I'm just giving you some examples from facility to facility, how people manage differently MRSA. And if you see now your roommates have tested positive, now you know you have a problem, right? So now you're kind of looking at potentially calling an outbreak. And now the next question is to be decided, who are we screening next? Are we screening that unit? Are we tracing back the contacts of contacts? Usually we don't isolate contacts of contacts, but we will potentially screen these people depending on the scale, depending on the impact. So a lot of these decisions are made right there in time, and maybe you want to, I would say you want to stick to same rules all the time. So in your facility, you should always do the same steps, same protocol, but it could be different from facility to facility. I hope that makes sense, because what I would want to avoid is confusing you, that you think, oh, today we can swab all the roommates, tomorrow we don't need to do this. So within your own facility, you always stick to the same rules, but say for Vernet, maybe different rules than there for Anika's facility, because there is not a lot of prescriptive guidance for us in how to manage some of these cases. So there is certain expectations, and they give us a framework, and then you have to find a halfway what works for your facility. So that will be the methodology of case finding. And then, of course, you start with your line list. So you put on your line list only the positive cases and only the healthcare associated, clearly healthcare associated cases. You're not putting anyone else on that line list. Even if you had, if you know that original case was a known positive, and if it's not a healthcare associated, they don't go on line list. So just so we don't confuse that. Okay, so then the next one that they're saying is observation and reviewing potentially implicated patient care activities. So what does that actually mean? So that means, what are the risks of transmitting particular microorganism from one person to the other through the care? And then us as IPAC practitioners, we often would come out on the units and just kind of follow our nursing staff, follow our physio staff, follow our physicians, and see how are they performing and where the breaches potentially could be happening. So we make documentation of that. Often we want to address some of these things in real time, but for interest also of gathering information that is not spoiled, so to speak, I would say hold off for some of these events interrupting the nurses because you want to get a full sequence of the care and see how are they performing. The other thing you can also do is have an interaction and ask them, so why is that you did this the care this way? Is this something that you do all the time? Was there a reason that this has happened? So that you will find out a little bit more if something is unusual for you. It could be also that there is the patients are asking for certain things done certain ways. So you may see that there is something unusual for us. It doesn't necessarily mean that is bad. It just may not be what we are used to seeing. There is also the consideration of, as I said, collecting some of these environmental specimens. So that would be in cases where we are talking about environmental contaminants. So if we are looking into these potentially equipment that may be shared and it's not properly cleaned or did not go to proper cleaning procedure, and we don't have a proper process in the facility that clearly labels clean from used and dirty, clearly has identified spaces between clean and dirty. So this would be something to take a look at as well. But you would be swabbing. So sometimes I find people just drag out these pumps or the vital signs machines and leave them in front of the room, and then, oh, Burnett needs Burnett needs a blood pressure cuff or whatever. Oh, there's one in the hallway. She makes an assumption it's clean, while someone just pushed it out because the room is getting too busy for them. And that's how these accidents happen sometimes, even when you have a perfect system that is labeled and there is spaces allocated for equipment. Sometimes these things still do happen. So when we are still in these kind of early stages of investigating the outbreaks, you want to start really early, taking things down, so to speak. So put all the outbreak measures in place even before we call the outbreak, because that will potentially save us of actually breaking into one. Sometimes it doesn't happen because we just simply caught something too late, but it does actually help with managing and also rolling the recommendations out, because it is a machine that is moving. So once we start putting measures in place, we can't expect everything to be immediately happening. I find people are very collaborative, supportive. They want to support us through this process, but sometimes they also need time to get things going as well. So originally we were saying identify and verify the diagnosis and establish the case definition. As you're going through your outbreak, you may go back and redefine your case definition. So depending again on your population, depending on symptomatology, they may not be presenting. Like I would say one of the good examples is norovirus, for example. It does say vomiting and diarrhea. However, in older population, you may see less of vomiting. So your case definition may have vomiting and diarrhea, not necessarily together as a one symptom, right? So if somebody doesn't have vomiting, but they have diarrhea, they should be also captured with your case definition. So we continue through the outbreak while we are either investigating either a pre-outbreak or a cluster or actual outbreak. You always continue searching for new cases, because for us to establish whether there is a further transmission, you have to establish, is there any new cases, right? So how do we do that? Syndromic surveillance and specimen collections. And also for us as IPAC, when we are managing outbreaks, we always have to verify that the measures that we have asked for that are still in place and they are actually following these rules. So I find sometimes especially in the long outbreaks, you see that some of these things start dying off slowly because people are just sick and tired of all the measures and that are put in place, and some of them can be quite draining and demanding, but also could be where you find these breaks. It could be weekends, could be also your shift changes and so on, because the communication is critical. So if the communication is not transferring between the units, between the staff, you will find that some of your measures that you ask to be implemented may fall off. So it is our responsibility to verify that they are. And then, as I said, we continue the surveillance. So you have to continue looking for new cases. You may also be expanding the geographic area or the population that you are looking at, depending on which way your outbreak is shifting. Or alternatively, you may be narrowing it down. So you may be creating cohorts, and some of your patient population may be discharged, and you stop. Obviously, you stop following them once they're in community, but you are continuing with your remaining cohort in your facility. So it could be changing depending on the nature of your facility and the nature of this outbreak. And then also, once everything's said and done, you want to take a look and complete your review of your data. So once we collected everything, you collate it, and now what is it we do? Some of these may be too complex for us as simple frontline practitioners. We may need assistance from the epidemiologist, and don't be shy to admit that you need that. There are people out there to support us. I had dealt with cases that I simply couldn't contain myself or manage myself from the statistical end, because it was beyond me. And I think I'm fairly comfortable in managing some of these numbers, but some of these statistical methods that are in use are way too complex for me. So I needed help, and I got help. So ask, you may get help. So our initial outbreak investigation always starts with confirming. Of course, we already covered that. And I think this is something that we have to focus on and remember that this is the first step. So before we start sampling, before we start running around the facility, we always have to confirm that there in fact is an outbreak in our facility. So this is something that you will have a question on your CIC exam. So make sure that this is ingrained in you. Always confirm the presence before you do any next steps, because as I said, it could be quite traumatic for everyone, putting people through, we have an outbreak. Sorry, we don't have an outbreak. Which I don't think anyone gets so upset with you if you don't have an outbreak. But I think if you get them all riled up and then you say no, that's where the problem is. Always review your lab reports, always verify your lab reports, verify that you have exactly the same name with a matching patient, because mistakes have happened there. If you have someone with very common last name, we have, or if you had patients that do have same last names and their middle names are messed up in the charts. So some of these things do happen. Always double check your name, last name, and the chart number, your medical record number. So that's the best way to verify if you're if it's the same patient. One thing that I want to highlight for you, even in cases where we don't meet the definition of an outbreak, your physicians, your ID physicians, may nudge you in a direction if they're seeing certain trends over a period of time. So we haven't had met the definition of an outbreak. However, over extended period of time, something is brewing. We may not be able to um, either identify the cases all the time. Maybe people get discharged before we test them, and some of these things are slowly brewing in the background. So they may actually tell you, okay, this looks like something, this looks like an outbreak. We are not meeting the definition of an outbreak, but let's put the measures in place and nip this in the bud before we have a bigger problem on our hands. So those are some of the potential outcomes. I've had it happen in the past. It's not frequently happening. For me, it was a CPE situation in particular, where we saw a trend. We saw these cases appear out of nowhere, and it was over an extended period of time. We weren't meeting the case definitions based on the time frames that these cases were occurring. However, it was rather alarming that we see them and they were all the same gene, and so there was something that was triggering her to think that this would be potentially an outbreak. So we put measures in place, swabbed everyone, cleaned the facility, and luckily nothing came out of it, but at least we have done our due diligence in terms of controlling this. So this may be something that you may also encounter in future. So keep your minds open for that too. Who is sitting in your outbreak management team? It depends on the size of your facility, depends on an outbreak too, depends on the nature of an outbreak, but you always want, usually we start with your IPAC committee team, and then you either keep exactly the same people, or you may actually deviate slightly. But you always want to have your IPAC physician, your ID docs, your own team, and then depending on the facility you're working on, whether you have access to a lab representative, an epidemiologist, usually you have an occupational health person. There is your public health representative, of course, and then depending on your unit or program, you may have a manager of the unit or a director, or both of them involved, depending on impact that the outbreak may have on their facility, on their program, depending on their own personal involvement. But you definitely have to include them in communication. They may not always appear on your meetings, but you want to communicate to them. Also important partners when managing outbreaks, of course, is our housekeeping staff. You may have, if it is like a surgical unit or cardiac unit, you may have a chief of that particular program also attending your meetings. And then there may be somebody from your senior leadership. It could be a VP. Sometimes CEOs will show up, again, depending on the type of an outbreak, impact it has. It's few factors play into that. If you have your run-of-the-mill flu outbreak, people don't tend to get so excited about these things, and they don't tend to join us always. If it was an outbreak that's raging for a long time, you may get their attention. And this is an opportunity for you to play into that, because now you have their attention and you can actually ask them to support you if you are having any of the challenges managing these outbreaks. Usually I would say I leave these communications to my management. If I'm in the managing positions, I take these conversations offline with them. No one needs to be witnessing all the drama that comes with the outbreak. So be careful how are you communicating, because it makes makes our life either easy or difficult. Let's put it that very frank and out there. And you may have some other members coming to your outbreak. So I would say at times I would have head of maintenance department come in because they want to know what to tell their own staff. You may have physio sometimes. You may have a number of different people joining you in, but they're not necessarily always a part of your outbreak team. And whenever someone is interested to come, invite them in. There is nothing, we are not hiding any information. We always have to be very transparent. It's just, I would say, some of these sensitive conversations, it's always appreciated if it's not like a social media event, really. So verifying diagnosis is another step. I think we've been through this many times. So make sure we have checked what are the signs and symptoms and verify that our patient, in fact, is diagnosed with an X disease that we're investigating. It always has to meet the case definition. So those case definitions are established, defined. And when we are reviewing case definitions, if you are not confident that your patient population that you're investigating is meeting this, so you would find, I find that often with respiratory diseases, when we have limited amount of swabs that is given to us through public health, and they say we will stop swabbing after 5 or 10. However, if these patients are meeting the clinical presentation, we are considering them to be positive. And I find this affects mostly long-term care facilities, not so much acute care facilities, because we are the ones in acute care facilities testing and responsible for our own patient population, where when you are sending swabs to public health, they put a cap very often on the numbers of patients that we can swab. So you would have a conversation with your team, of course, and with your ID doc to see if, so if you're seeing some of these cases that are presenting to you, but they're not necessarily meeting the true case definition. So you may be looking at, I had a case, I had actually an outbreak like that, where our patients were all slightly off, as the nurse would put it, but they were not meeting any of the symptoms. So they weren't presenting with your typical symptoms. So our patients didn't have fever, they had elevated temperature. They didn't have any sore throat, but they weren't complaining rather of sore throat, but they were refusing food because obviously they couldn't swallow. So it was a specific population, was dementia population actually, that was, so some of those you'll have to adjust a little bit and take maybe a different look at your patients. And when you decide to adjust, always let your public health know, and always have that reflect in your line list, because anyone coming after you looking into that line list, if you're putting cases on that they are not lab confirmed and they're not necessarily meeting this traditional case definition, you will have some explaining to do. So instead of doing so, always you can maybe another way around it is also making a memo and attaching that memo into your line list, so whoever looks at it, they can see that there is the communication that has happened and there is agreement between your facility and a public health to deviate from traditional case definition. So your case definitions for C. difficile, that is clearly laid out. PIDAC document has them, Ministry of Health has them. So your definitions, they're the same across. So that's what you follow. So it's lab confirmed case with diarrhea. And I think the stumbling block for a lot of people is what is diarrhea, and there is a very clear definition of diarrhea in PIDAC document. The other way around the setting up the definition, sometimes you will have no lab confirming that your patient is C. diff positive, and it does happen on occasion. However, if there was a diagnostic imaging completed, you have any colonoscopies done, and you actually can visualize, well, wouldn't be us, would be a physician visualizing these pseudomembranes and documenting as such. They will often say in their notes, C. diff, clinical presentation, and they tend to be very prescriptive and very, very well documenting their diagnosis without a supporting laboratory result. So they will say, this patient has so many diarrheas, they have pseudomembranes or toxic colon, everything is in keeping with C. diff. However, we don't have a lab result to prove that, and they're diagnosing patient clinically. So that's absolutely acceptable, 100% acceptable from IPAC perspective. It's just a little bit kind of work for us, and it's not common. It does happen, but it's perfectly fine. And then of course you're looking at also the findings that could be your pathological specimens that someone has collected for us. So those are some of those definitions that our patients have to meet to declare this case C. diff. So what's the difference? So now you have a C. diff as diagnosis, and you have that established that this patient now is C. diff positive. Now the next step to it is actually determining whether that is a healthcare associated case for us. So it could be that is something that is not HAI, but also could be something that is an HAI. So you're looking at that other definition that speaks about the admission within the 48 hours, previous admission. So again, referring back to your PIDAC document. Okay, so again, another definition that's very, very clear. It's your influenza case definition. So again, very clearly laid out. It has to be a laboratory confirmed and appropriate clinical specimens. Or alternatively, you're looking at someone who is presenting with signs and symptoms. So you could have somebody that just has signs and symptoms. We didn't swab them. I mentioned this in a previously a couple of minutes ago, but also could be looking into your titers in this patient population as well. So that's another way of looking into the case definition. Or you're looking into the epi links. So if we know for sure, for example, I'm in a room with Vernette, and Vernette tested positive for influenza. And so now we move me out of the room because I'm now exposed, and you don't want to keep me any longer for the risk of me actually presenting with symptoms. And now we just you moved me out of the room, and then overnight, just to spice this discussion, there was something wasn't properly documented. People were aching and needing beds, and they ended up putting me in a room with Crystal. So now me, who is exposed, ended up in a room with Crystal because I was still asymptomatic. I was fine. And then the next day, I have now present with signs and symptoms. You may or may not swab me. Now Crystal is at risk as well. So those are your epidemiological links when you know for sure I got it from Vernette. Vernette was my buddy for some time. We were together, rooming together. She tested positive. Now I'm testing positive. So that's your epi link. And then, of course, you can do your detection through the PCR as well, and RNA and different types of tests. Well, I don't know. Leonard is very quiet. I usually pick on him, but I don't know if he's even around. So I kind of pick on you tonight. You're going to be my diseased buddy tonight. So it's important for us to communicate. And I think um, I think I mentioned this to you guys before. I feel that us as IPAC, we kind of tend to shy away from being out and about and discussing some of these findings. We are very good declaring outbreaks, and we are very good putting measures in place. But I find people often complain about the communication coming out of our department. So it's a fine line, really, whether you want to inundate people with emails and sending stuff out. Some people don't read emails, so you have to find a balance how to do the communication. I would say picking up a phone to talk to your managers, picking up a phone to talk to the public health. You may also follow up with some details or specifics around the cases that you're reporting to them. But usually for me, it's like, hey, you know what? We have a new case. I will be sending you the details in an email. So just heads up, this doesn't look good this morning. So that would be kind of how that looks from me, just kind of giving everyone a quick runaround. Call my manager, call the unit manager, and public health. That's how I work that thing. Of course, my team knows because we talk in person usually. And then the rest of the communication, you have a little bit of a breather, really, to assemble some kind of memo or an email that you can send. And usually from us, we tend to send emails. Either our managers, the team managers will communicate this, depending on dynamics on your team and depending on how different facilities work and how different programs breed. But it could be, sometimes you will, I worked in departments where my manager would say we are responsible for communication that for everything that is in our portfolio, and I worked in facilities where all the communication is coming out of my manager and it's only one voice is heard. So depending on how people organize themselves, for a lot of these things, neither here nor there for us. Usually there is a lot of templates that we use and you just change certain things. Be careful when you're using these templates. If you're using older documents, sometimes information sticks in there and we don't see it anymore. We are blind to some of these. Always start with a fresh template would be my advice. And then couple other things to communicate is also could be your website. So we have internal web pages and external. We are mandated to communicate, to be transparent, to put that up. I find the units will be calling the families. I've never called anyone outside of my own home, so to speak. But I know they will call the families and communicate, and also, of course, the signage. So you have to post a signage at the entrance into the unit and throughout the unit as much as possible, and also very, very visible and prominent into the entrance into the units, because people get really upset if we don't tell them that there is an outbreak. So some of these things they get upset just because, and sometimes there is a true risk for them. They need to know, but it is standard to communicate and do so well. For us as IPAC, I mentioned before, we have close relationship with the lab, and the closer you keep them, it's better for you. So if you know buddies out there and have friends out there, they will call you and say, hey, you know what, Vernette, you have that patient Sharon Fernandez. She has potentially looking something like an MDRO. Don't know, we are rerunning the test, but I don't know if this patient had anything with the other patient. We found another one. Also, Aisha also tested, so we are running these tests again. So maybe you want to check if they had any common points if they share the rooms, and you can do your own little research when they call you back and say, hey, false alarm, nothing, but just kind of give you a little bit of heads up, and you can start prepping in case something goes wrong. So literature review, of course, always there is a couple of books that I use as my reference. IPAC, of course, is our Bible. I find in Ontario, we kind of always swear by IPAC. It should be like one of those, I swear I will obey IPAC when I become an ICP. But I think for most of us, that is our home, our residence, where we are getting our guidance from. And then the other documentation would be your Red Book, your Hyman's manual. I like Hyman's manual because it's so small, and it has, like, I don't even know. Oh, yeah, it's here. I'll show you. It's my little friend. I have it always handy, and I look at it and take a look when I need something usually for me is some of those diseases that I normally don't deal with, is kind of looking in really quickly for incubation periods. So those are kind of my go-to my go-to books, and it's really neat. But everyone finds what they like to refer to, as long as it is a recognized and coming from a reputable source that you are using as a reference. So I already spoken about this briefly. When we are looking into our methodology, always have a conversation with your team. And once you guys have settled on what is gonna, how is our investigation going to shape? What are we going to do? What days? Create a little table if you're doing a prevalence. So you have kind of ongoing table to refer to, especially if you're going on weekends and your colleagues are taking over for on-call, so they can look back at, say, oh, you know what, it was, the point prevalence was done on July the 28th. It's coming up on the 31st, so they know what to look for the results, for example. But also they can remind your units on the weekend to do so, because we want everything to go as smoothly as possible. But once you have established the process, the next steps, and what are we going to do, always communicate this to your unit manager. You don't have to communicate to their directors. You will know if those people want to be involved. Sometimes they insist on being included in conversations. Sometimes they say just deal with whomever is their manager. They don't want to get too many emails. They're dealing with other things, but sometimes they do. So you will know it. They will tell you, can you please copy me on your communications? And you do so. So no harm done. And tend to keep a same line of communication, or a same thread whenever possible. If you're changing topics, that's fine to start a new conversation, but I tend in my emails to use the same thread so people can refer to the previous conversations. That also can kind of turn wild sometimes if some of these conversations have kind of like sidebar conversations, so be careful not to forward some of those pieces. But I usually follow with my last communication that went out of my desk. And now if I say next point prevalence is July 31st, and then if now we got results, I will pull my last email and send that out again, saying, hey, there's an update. We got all results back, they're all negative, or whatever is the status of your prevalence, but always include your people. So this is kind of really crossing between communication that I'm speaking here, but do communicate to your managers, to your unit managers. So there's your line list, you guys. I spoke about this many times before. I think this is you should be quite comfortable with knowing what goes into these line lists. I think I have here, this is a line list that I created with your names, and I think that's the one where Kyle and Leonard are pregnant. So, and I think Sharon has cyclospora, or I don't know what's going on in this line list, but I just kind of look at it how you can filter it. You see it on the top here. Those are the filters, so you can sort your line list based on either gender, or you can sort it based on the unit or a specimen type. Of course, I wouldn't have it any different. Like, it's not really a communicable disease. Well, let's say it's not. But yeah. So I got somehow diagnosis for Leonard and Kyle to be pregnant. Yeah. So at the back of your line list, you pull out these cases. Always, I'm just used to doing this like this. I don't know. I actually don't even know if there is any other way of doing this line list that you can't pull out information. But it's important that you stick to same terminology, same type of I guess what formatting is the word I'm looking for. Formatting of dates. So what I have done in the past, where I shared a line list with my colleagues, I would include drop down menus. So we are not free texting anything into the line list, so you can stick with the same set of information. So if they're trying to force something that's not there, whether by accident or because they would like to enter something else, there is no other option. So it's either yes or no, or not applicable. So you can pick one of those, for example. Or if we are looking into the specimen sites, it's either nasal or nasal rectal or rectal, or it's a sputum. So you can, when you need to filter and create meaningful reports, you can actually pull that out. If you have line lists that contain a lot of mixed information, different ways of entering, for example, dates, so your months get confused, so you suddenly have someone is entering first a day and then month and then year, and the other person enters a year and month, so it becomes very, very mixed, and you can't really extrapolate what you need out of it. So that's why you find usually it's one person assigned to do these line lists, or if you're using your charting systems, if you're lucky that your chart systems can produce these, then you don't need to do this. Yeah, so if you want, you can, I uploaded it for you guys. I don't even know where was it anymore. I think it was in lesson 4, lecture 4. I'll find it and share it with you. I uploaded these documents for you. You can take a look there. There was, I had line lists, I had your professional exposures, the occupational health exposure documents. Not in lecture 4. I'll find it and just redirect you there. But it's in one of the previous lectures. Maybe it was in unit 5. I can't remember anymore. I'll find it. I don't want to waste our time here looking for this, but you can use it any way you want, really. So, but as I said, it's important to agree on some of the terms or lock these selections so no one can mess it up. So with regards to your patient care activities, I mentioned this originally when we went through kind of headings. It's usually the care that you would be observing that can put your patients at risk. It could be also just the actual care itself. It may not be nothing wrong with the procedure. It's just that the procedure itself comes with a risk. So it could be like your central line insertions, so could be dialysis. So on its own, it's a risky procedure that does increase the risk of exposure to your patients, but it also could be something that there was a breach in management and now we are putting our patients at risk. We didn't clean our hands, we didn't clean the equipment, or someone decided to MacGyver some of the equipment to make it, they think, easier, or they didn't have enough of certain supplies and they decided to um, make their own devices, and that creates a problem, for example. Or if we are expected to use certain devices and then we are, for example, reusing the machine, but there is piece that must be removed and replaced. So did we replace the entire length of that device or length of the line that needs to be replaced? So kind of looking into some of those nuances. And for us, it's often we have actually to learn ourselves what we are looking at. A lot of conversation, a lot of reading, policies, talking to experts. So for example, I can think of a couple of things where I felt like fish out of water would be use of high flow machines, where I actually didn't really know how they function, or so I had to talk to the respiratory techs, and they're so great and so helpful in helping me understand how should something ideally function. So you can even read up on things and you still don't understand how these things work because it's maybe completely foreign topic to you. As I can tell you, this was like with anything that comes clinically, a lot of these things are very often very foreign to me. So that's interesting. Environmental or swabbing of your colleagues. So we do not normally go out swabbing our colleagues. It's not something we are too quick to do. There are some cases where we would request the collections. So in cases like, say, real respiratory diseases, in cases where you can't manage an outbreak, for example. So if you have a raging MRSA outbreak and we have done everything that we potentially and possibly could, and we still cannot stop the spread, we are still seeing new cases, and we don't know why. So that would be one of the case where we would say, okay, now we have to look into our staff. I can tell you also for group A strep, you could be also looking into staff. When you can't control some of these outbreaks, usually we would say that would be a good call to consider, but it's not something that we do routinely or easily. Of course, your environmental swabs, that would be swabbing the environment, swabbing machines, swabbing shared equipment. What is really important when you do so, when you decide to swab the environment or collect specimens that are not of humans, always call the lab and ask them how would they like you to proceed, because some of the environmental specimens need to be enhanced, need to be enriched. So if we send swabs that they can't work with, it's useless for us and them. And they will always tell you how they want certain specimens obtained, certain specimens processed and I guess saved or before it hits the lab. So for me, I usually, when I was doing any of these, I walk them personally down to them and just go through the paperwork with the lab people, because I find it's easier for all of us. If there is something missing, we can fill that right there, right in a real moment, in real time. Yeah. So when it comes to equipment, also what I would like to bring to your attention is look at the possibility that this equipment may be also damaged. And also could be something that's cracked, or maybe if you're looking into packs, for example, they tend, the wires on the packs are not always compatible with the cleaners or disinfectants, so they will tend almost to kind of melt that fine rubber plastic that is around. So you may end up with something that is actually adhering and become so gooey and gunky that will collect the dirt rather. No problem, Suganda. You just we are almost there. A few more slides. Have a good night. So with regards to the specimens, as I said, talk to your lab, and they will advise you how to do the specimen collection. What do we need to do from the culturing perspective? They may need different agers to grow the specimens, so they do appreciate heads up before we send stuff to them. But also, when you are looking into the collection of any of these unusual specimens, speak to, of course, to your team, but speak to your epidemiologist and see what they would also suggest. They may have in terms of specimen numbers, or so you can actually get a valid result and something that they can use in producing reports for you, get you a good sample size, for example. So when you are out and collecting specimens, I know we tend to kind of, once we show up with this magic swabs, or everyone wants everything swabbed, so you suddenly start seeing people are dragging stuff out of supply rooms and bringing you things that you didn't even think about swabbing. So be careful what you're collecting. Always think about how will this play into your case investigation or your outbreak investigation. So if you're looking into water loving organisms, there's no point of collecting something that is a dry surface, for example. Or if you're looking into organisms that tend to travel on air currents, that's what you want to collect. You want to collect air, or potentially surfaces that are near the air exhaust. There's no point collecting water, for example, in these instances. So be meaningful what you're collecting, if that helps. And as I said, always talk to your lab. They will appreciate, and let them know what is that you are what is it you're going to be swabbing in terms of surfaces, but also let them know what are you on a hunt for, so to speak. So once we're done with our investigation, everything is completed, we have to complete also to kind of wrap up our case. So if we have changed the definition, make sure this is reflected in your final report. Make sure that even when you declare your outbreak over, you may want, in some cases, continue screening your patients just in case something is lagging behind. I've had outbreaks that we declare over, we continue with surveillance, and only to find out that we now have declared outbreak again on the same unit. So whether there was something missed, whether we actually have passed the length of the disease and incubation periods and all that, but sometimes it happens that we catch something through this follow-up as once the outbreaks are declared over. Always other things that you always want to also follow through is your measures, your outbreak control measures. So if you have, say, enhanced cleaning, or you're asking staff to do hand hygiene or PPE audits, so stick with that for a little while so you can have it, so it's not that abrupt stop. And especially once you open up your units for new admissions, you don't want now things to kind of break apart again. Okay, so communication, who are we communicating? So throughout the outbreak, with your team, with your ID physician, with the managers, with your close team and your liaisons and your partners. You're communicating broader and wider. So when you are declaring an outbreak, that goes facility-wide and outside of your facility. And then also when you declare outbreak over, that's another one that you go broadly. So these people that you post information on your web page, they don't need to be a part of your everyday communication or your weekly updates or weekly summaries. So that's kind of more a general status update. For that, you may also involve your IT department and your PR department, because you want to be succinct. You don't want to share too much information. You want to be careful with what are we actually saying out there without alarming, especially alarming people that are outside of our facilities, so they may not necessarily understand the terminology. So your PR can help you with formulating your statements. We tend to ask for these to be short, but keep it to the point. So we declared outbreak, it's an influenza outbreak, it's on this and that unit. And usually, so I picked out of two public notices here from two different hospitals. They had here an influenza outbreak, and the other one is the what did they have? A COVID outbreak there. So it's just like a public information that is publicly facing. I just grabbed it off their website. So you can see that here, where is the Markham Stouffville one. It's just a one-liner. There is not much. And so there you go. I think Anika was texting Karine here, but it went to all of us, so carry on. Your common sources, it could be, so usually when we are talking about your common source outbreaks, we are speaking about your food, or it could be waterborne also, the same thing. And usually when, I think we've been over the maybe 2 weeks ago, we've been reviewing these. So you may be seeing something similar in your exam, where they ask you to present this the epi curve to you and ask you whether this is a propagated or a common source. So you have to be able to kind of look at it and say, just based on the curve, which one is it? So there is your propagated source. You see how they're different. Usually with your common source, you have this one peak and it kind of comes down. Where you're propagated, they tend to have more of these peaks going on. Okay, so usually with your propagated outbreaks, you're thinking of things that do get transmitted from an individual to another individual, and then they have their own little clusters around them. What is our role as an IPAC practitioner during an outbreak? Well, we kind of tend to take a center stage through this process. Everyone kind of, if they didn't know you before the outbreak, during the outbreak, and after, they know who you are. We are the ones who review the cases. We are the ones who define, set the definitions for your outbreak. We are the ones who declare the outbreaks, and we are the ones who declare the outbreaks over and everything that goes in between. So we are the ones who are communicating with your front line. We are the ones communicating to the lab. We are the ones communicating to the public health. So this is where you actually shine, and you can show who you really are and what you really know. And we partner with the public health during the, usually just before we declare outbreak, we talk to them. They come to our facilities. They don't come so much during COVID. Usually it's all phone conversation, but in the past they would come and visit us, and we will go over some of these things together. They would take a look at our recommendations. They would take a look at some of our strategic approach to the management and provide their input. So there are our partners, but we are also obligated under the Health Protection Promotion Act to report to them. So here is your infectious diseases protocol. There is the entire protocol that includes a number of different diseases that you refer back to for your for your case definitions. So you can find that on the ministry's website. If you just Google it, it will come up. So here is your next step, about a little bit about bioterrorism. And as I mentioned, a friend of mine was telling me that she found that there's quite a lot of questions about bioterrorism. So it may be something that is more maybe brought into different cases. I can't really see them overtaking the exam with bioterrorism, but who knows? Maybe it was just her impression that she saw so many discussions about it. But generally speaking, when we are talking about bioterrorism, it is something that is known to be with intent to harm somebody. So it's over time in historically has been used. Not necessarily that people are so fondly looking back into that, but it has been done in the past. And it is usually the microorganisms that we are looking at, viruses, bacteria that can be actually utilized for such purposes. We also, sometimes you will find that, I don't know if you guys remember the early stages. I mean, people still talk about it, but truly at any beginning of pandemics or any of diseases that are of a high concern for us, there is always that potential risk that something could be actually a result of the intentional spread. So there's this case in Oregon that actually the cult has brought in salmonella into the salad bars, and actually has caused about 750 people to get sick with salmonella. Also, before this right approach to resolving their issues, whatever they are, we also have seen that in the wars and during the war times, the enemies would put cadavers into the water supply, and that way try to eliminate their opposition. And then, of course, something that we all are aware here, and I think this is something that's been taught in schools as well, is the smallpox here that have affected the Native American population when they were actually provided with blankets that were laden with smallpox. So there is always some of that vicious thought behind, and some people would argue it's no different than a bullet. I kind of feel it's coming too close to playing with too many lives, and I think it's unethical, and it's completely out of control once we decide to wipe out somebody with diseases. So couple of other things that you may remember from the news would be anthrax, and in the states there was some letters that were mailed to politicians. And if you are really not into the news and not watching the news, there's so many shows that stemmed some of their series and some of their episodes covering this particular event. So what actually happened was there was 22 cases that were affected with anthrax, and 5 sadly ended up in death. And with all of these cases, you find often is a lot of investigation. They're very costly, and they cause a lot of panic. So the panic alone does have a huge impact on economy. So if we are not focused on what we are doing at work, and we are only talking about anthrax potentially coming in manila envelopes in our office, how efficient can we be at work? So those are some of the strategies that they're pulling on. They may not always have a huge impact on the population and affecting a large number of population in with the actual disease, but the panic does the trick for them to get people riled up, and everything kind of comes to a full stop in those cases. So it could be bacteria, could be a virus that they're using, or could be toxins in some cases as well. So depending on, I guess, what is easily accessible to them and what they find to be uh, also easy to distribute. So usually when you're talking about affecting large groups of people, you're looking into something that is either waterborne or airborne. So if some of these microorganisms can be dispersed in such fashion to cover large geographic areas, that's what they prefer. Usually airplanes or any sort of dispersing vehicles, I would say, something that they can maybe even cars that they can pump air out of. Those are usually visible and not something that they can easily get away with, but airplanes are perfect for some of those potential attacks. Also water. So in the war that I can speak from personal experiences, often would be water supplies. And even without contaminating the water, cutting off water on its own is a huge impact on the population. And also could be something like bringing again those cadavers, or just simply contaminating water with feces. It has a huge impact on population, and it does actually cause illness and death. So with bioterrorism, yes, they are aiming for the physical ailment, but they're also working around the impact that panic does cause in the community. So with our emerging infections, I think these are always, whenever something comes back, there is always that discussion that could be something that is lab generated or something that's being distributed through the community, where it is most often, more than not, is that actually things do get spread through humans or by animals as well. So some of these things do come back. Some of things have been around. Some of the suspicions is that was reading while I was reading about this particular lecture is that possibly plague will be the next thing we will see come back again. So let's see what happens. But as I said to you in the first couple of slides, we we have battled in the past, and you remember Black Death and coronaviruses that have been in different shapes through SARS or COVID or MERS. So it's not excluded that the next one would be again some type of coronavirus that has evolved. We are not out of this a particular pandemic yet and no end in sight really, but we have to be proactive and think what would be the next thing coming at us. So those are some of these emerging diseases that you may be asked about, and recognize that some of them have been around for a really long time. It's just that they may be new to the region or refreshed, so to speak. So came back from the olden times. Flu is one of those that never goes away. I feel this year was unique for that. And you will find that natural disasters will propagate these emerging infections, come back. Usually we find because of the lack of access to water or the side effects that we end up with, like no power, so the food starts breaking down. People, if it's a longer period, people will go out and try and hunt on their own and do all sorts of things that may not necessarily be something we would normally go through the process. And I also find that in modern times, a lot of proper food preparation in case we are forced to go and fetch for ourselves or go hunt. A lot of people don't know how to properly clean or how to properly kill animals or actually prepare any of the meat in a safe fashion. So I think that on its own creates an issue. But I think we are lucky to have all the grocery stores around. So let's speak about some of our pandemics. So that would be diseases that have affected, of course, the population across the entire globe. And in the 20th century alone, we have seen 4 major pandemics take place. And of course, there is the flu in 1980, 1957, and 1968, and then the one in 2009. So on the right hand side, it's just an estimation. That's not really a number that we can confirm or deny, but they're estimating that the next influenza pandemic could affect about 30% of the US population, which would be close to 90 million individuals. And so why are we discussing these numbers in our course is the impact it has on the healthcare system and the burden that creates. So usually we are talking about your critical cares and emergency departments and how are they affected. And some of these resources that I was looking at have been written before COVID, and it so clearly speaks about it, because I think COVID has created a whole different world for us to think out of the box and think about different spaces to provide care in particular. So we learned that there is really no limits for us. We have to think about inside the walls, but also thinking outside of the walls of our facilities to provide care. So the pandemic is usually broken down into these phases, and you can see from the side it's 6 phases. So we have this like low risk of human cases to the far end where it is efficient and sustained human to human transmission. So it goes through the low to high risk and to no or very limited human to human transmission. And then we have established evidence of increased human to human transmission. And then there is evidence of significant human to human transmission. And so if you're thinking about influenza, usually we are talking about these like avian or swine flu, where the transmission occurs within the animal population, and then the risk is limited to humans. But once it jumps into the humans and it spreads across the globe. And why does it spread like fire? It's again, it has to do with immunity. As much as we always say influenza vaccines and influenza does come back, there is also some immunity that we do carry in, and it does not spread, especially these new strains, emerging strains of influenza that are completely new to the entire population, will spread like fire and affect a huge populations. So with the influenza pandemics, usually you will see that it comes kind of like a tsunami, I would describe it. It comes in these circles, almost like it almost ripples through the population. So it comes in 6 to 8 week periods. Usually your attack rates are high because of the, as I said, involvement of these new viruses, new strains that we have never seen before. And the estimation is that again would be the affected population would be in about 30%. And then with your pediatric population, they anticipate or estimate about 40% of the pediatric population to be affected. What are they talking about? What we could be seeing in future pandemic could be SARS, could be MERS, could be plague, or could be good old-fashioned influenza. And the times that we were talking about influenza like a good old thing. So what we need as IPAC practitioner to do, so you may be involved in preparedness within your own facility. That often does involve training of the staff. You could be involved in estimating and projecting the need for PPE and calculating. If you are, there is great resources on CDC website. They're calling it burn factors. So you're looking at how quickly will your staff be burning through the PPE, and anticipation, how much do you need so you can project and plan. And what COVID has also taught us is that as much as we can project and plan, we still may end up with absolutely nothing in our hands because there are things that are out of our control. Then CDC has a very specific recommendation. We do have also in Canada a similar recommendation from our ministries, speaking about stockpiling some of the supplies. Although before COVID with us, our emergency preparedness speaks about food, medication, blankets, clothes, and having some cash on, and working out plans within our own families if we are at work or school, figuring out the meeting places, and having a designated spot if our house is affected, or if we can't go back home, where would we meet? So those are some of the way our emergency plans works for our communities. But CDC has recommendation on stockpiling respiratory protection. If you know anything about the stockpiling, we know how people stockpiled for pandemic. That was quite crazy. And as Burnett was asking us, who needs PPE anyway? So when you are investigating a disaster, usually for any one of us, this wouldn't be something that we would be reviewing on a larger scale. We may encounter something like that in our facility. So you may actually deal with a lot of patients coming through emergency. So if you're in an orange zone where you may be in a community that may be serving some of the high risk populations. So I'm thinking about like your nuclear plants, nuclear power plants, or maybe some military bases where they could be under attack. So those would be some of hotspots. But also if you're dealing with your infectious diseases, you could be in a hotspot, like for some certain transmissions if something is happening only in certain pockets. Usually when we are talking about bioterrorism and high impact, you are talking about congested areas and congested populations. So I would think about highly densely populated city. They have no interest in spraying a rural area and affecting 20,000 people when they can affect 6 million people, right? So kind of thinking about more of that. And with some of these bioterrorisms, what also would be interesting for us to know is unusual diseases. So our frontline physicians that are dealing with the run-of-the-mill diseases may not be quick to recognize some of these agents or presentation. Also, the incubation period could be anywhere up to 2 weeks, 3 weeks. So after the event has taken place, the attack itself, now we are dealing with the consequences that may be delayed. So that's something to keep in mind as well. So when we are asking our patients presenting at the facilities and we asking them if they had traveled, and suddenly you see that you have an influx of people with similar symptoms, there will be something to be concerned with. What are the possibilities that this is something that is not just affecting one or two people or a household or maybe a business? This could be something on a broader and wider scale. Could be also that you have a couple of people that start coming in one hospital, then you have a group of people coming in another hospital. So for us, from that perspective, is really important to work on these integrated systems that do speak to one another and the labs that also communicate. So those are kind of things to think about. And yes, Amandeep, you're absolutely right. You're right. There's the stockpiling of everything, right? So toilet paper was definitely one of those things that people were hoarding. But for us, it's important to keep an eye on some of these symptoms that actually can be increasing and buying, say, toilet paper. So I don't know, and I really can't speak about Canadian government, but apparently in the States, they have ability to screen for increase in buying some of these supplies like toilet paper or medication that is purchased over the counter, like flu remedies, or they also have means to screen the social media, and apparently they're saying they have done it and used it in the past to actually that triggered that COVID, where they knew they had COVID in the community before it was confirmed through the social media because people were talking about some of those key terms. So something that obviously states maybe have a little bit higher developed way of keeping track of some of these things than we do here in Canada. And I really don't want to know that someone knows that I'm buying so much toilet paper, but I know from that in the States, from their attacks and where they were looking in supplies being purchased that can make bombs would be probably something that they likely just somehow modify those search softwares to look for different items, because in the States, they, if you're buying like fertilizers and ammonia and batteries, suddenly you become that person that they would want to talk to. So maybe this is something that they just use a similar algorithms to find these particular purchases to identify where their hotspots are. But I don't know. I think with how people went crazy with toilet paper, that was, I think that would be completely useless for them. So this is exactly what I was saying. They were using the social media for screening, and apparently they were using this to see the influenza outbreaks in 2017, 2018 to 18 to identify where the spikes are. So hey, watch what you're talking about in your social media and what you're posting. If you have a runny nose, maybe not post that on your Facebook. I don't know. So also important for us to know is who are our populations at risk. So there are certain groups that will be affected more than the others. So definitely pediatric population. They also don't have fully developed immune system. They're not immunized naturally, or through either acquiring diseases or getting their vaccines yet. So they're the ones that we should really keep a close eye on, and they're very, very, very vulnerable population on just based on their body size, and their inhalation rates puts them, respiration rates rather, puts them at a high risk for exposure to some of the airborne type of contaminants. So something to keep in mind as well. And then also, because of the immunization that has taken place for people who have lived in the time of the smallpox when the vaccines came through. So that stopped, of course, that vaccination stopped. So they would be definitely at risk of acquiring smallpox. So the other group that we also should be keeping close eye on is our elderly population. So as we age, our physiological functions, of course, decline. So we do have also some other undergoing diseases, underlying diseases. So that also adds to the risk as well. And the if and this is, we can speak to this with certainty when we are talking about COVID, for example. We know that has caused death in our elderly population in much higher rates than it was in the younger population as well. So the number from IPAC is that it does increase for about 40% in mortality rate, not just for COVID, just generally about infectious diseases. So other thing that I can link back to the previous discussion is this temperature disassociation, where with elderly population, you will not necessarily have fevers, and this is something that we may be looking for. So you may actually need to change that when you're assessing your elderly population. So those are kind of interesting things to keep an eye. And then, of course, your immunocompromised population. This could be anyone, any of your cancer patients, dialysis patients, patients that are undergoing treatments for other infectious diseases already. So depending on, again, who is in your population, that would be your focus. But if your immunocompromised patients who are already battling something else are exposed to infectious disease, they're the ones to be at higher risk of acquiring and also ending up with fatalities. The important things about all of these three categories is that their symptoms may be masked due to different factors, age, other illnesses. So you may think, oh, this is how they normally would present after the treatment, or this may be attributable to their other disease or other conditions. So you may be misled. So it's very important to keep that in mind, that we may not necessarily be quick to identify these particular symptoms in the population that are pediatric, elderly, and you're immunocompromised. So with pregnancies, we normally wouldn't say that they are immunocompromised. So that's, just keep this in mind for your CIC exam. They're not considered immunocompromised. They are actually a population at risk, right? So the reasons for them is, again, the respiratory rate changes, especially at the later pregnancies. So you may have some of those contributing factors. The pregnancy on its own, it's really not a risk factor, but it has been linked to show that in pandemics, the risks are amplified for the pregnant population. Mortality rates also have been documented to be higher in pregnant populations. So that's something to keep an eye on for your exam as well. And then what we know, which is interesting actually, is that in with MERS, the uh, the fetal death was really high. So it's about 30% increased in relation to other pregnant women who did not get exposed to MERS. So something to keep your eyes open for your CSC exam are those kind of unique turns with some of these diseases. And of course, Zika, we know that, SARS, of course, smallpox. So all of them can actually lead to either spontaneous abortion or preterm birth. And here there are colleagues. We often don't really think about them as population at risk. However, they're knee deep in blood and up to their ears in all potential diseases. Stress would be another factor that would put them at a higher risk. With being overworked and stressed out, they may not always follow through with all the recommended procedures, especially when it comes to donning or doffing. Some of them will also say they simply are there to save a life, and they will omit on some of the steps to protect themselves. So keep your eyes on them when you are dealing with some of these potential bioterrorisms or any sort of, even with COVID, we saw that many of them, although they were scared, they were still cutting corners in protecting themselves and taking approach in diving in saving lives. So keep your eyes on those people as well. Those are our colleagues. We tend to forget about them because they're right there in our face every day. So that's something that becomes kind of like a second nature to us. We work with them and we don't really think about them often as population at risk for some of these extreme situations. We have to make sure that when I say we, I don't think us as IPAC necessarily, but us as healthcare, and in healthcare facilities, we have to ensure that the influenza vaccines are offered and available, and depending on the recommendations or expectations of the facilities in the States is different, and Canada is different, whether that immunization is taken. With Canada, we still have a choice. So I hear a lot of rumbling about COVID vaccine becoming mandatory. We had some really good discussions in our discussion board about whether should or should not be. And I find that IPAC always kind of leans towards mandatory vaccinations. I think that's why we end up in this field, because we do believe in prevention and we know that that's a way to prevent diseases from happening. So I think that's what's important to highlight here. So when you are studying for your exam, do make a note that there is differences between Canadian recommendations and recommendations in the States as well. And then we are involved and will be involved with selection of your PPE. So you may be asked to review. So that's that as far as IPAC gets involved with that piece. The test fit for respirators is not something we do. That would be under occupational health. However, for your exam purposes, it would be something you need to know in terms of the how often, what's the expectations in terms of testing, and then also when you are wearing your N95, how are you ensuring the proper fit. All the facilities must have a sick leave policy and encourage sick leave culture. So we don't end up with Sharon coming to work and dripping out of all her facial orifices on us because she decided she wants to come to work before she gets punished for taking a day off. So those are some of the policies that definitely need to be in place, but also having culture that encourages those behaviors, not putting your staff on behavioral procedures because they're taking a day or two off because they're sick. And then for us as IPAC, we always have to make sure we work with occupational health here to provide the training to the staff. So we kind of tend to cover the micro piece and epidemiology piece to them in understanding like the chain of transmission type of thing, where your occupational health partners will talk about the preventative measures, whether there is vaccinations or there is post-exposure prophylaxis. So that's when we kind of talk to our colleagues about some of those interesting topics. So here is your categories in terms of, I don't think you will have to remember this. It's just a list that they have. Know that there is 3 different categories of the bioterrorism agents, and that's how they have them broken down. I would say in your category A is probably the ones that are easy to acquire and easy to distribute. So they would be in your category A. And then some of those category C's would be your emerging infectious diseases. So they're not really easy to come by and not easy to spread. So those would be just kind of different categories for you. Don't need to memorize this. Now I was going to ask you to list all of these. And then when we are talking about preventions of any, either it's your bioterrorism or suspending the spread of the diseases in terms of the newly evolving or re-evolving, there is always that support that comes from that is non-pharmacological intervention. So what does that mean really? It's speaking about your, of course, your PPE, closing schools, working from home, canceling some of those large gatherings like concerts. I'm dying to go back to concerts. I don't know about you guys, but you can recognize this just from our life in last 2 years, that you see that all of these measures have been implemented in controlling and managing COVID. So those are just some estimations again. If you need a good calculator, let me know. I can show you where to download this from CDC. Our own ministries have it too. I have some of my own documents I can share with you if you need it. But always keep in mind that you always have to, when you're estimating, you always estimate up. You never estimate down. So you're better off having more than not having enough. And there is your hospital that was, it's a field hospital. I'm sure you have seen this picture. This is in London. And this is a modern time field hospital. So Sunnybrook has set up some tents, I think, and there's some other hospitals in Toronto area that have set up tents in case of the high influx. For these field hospitals, you will find they tend to be makeshift always. There's a couple of facilities in the States that actually have designed and planned to activate their parking lot. So they have mobile or remote controlled head walls. So you can actually bring up from the underground, the head walls that connect to oxygen and all the supplies that you would need in ICU, and they would just erect a tent above it and bring up the beds and rock on. So let's hope we don't need this. But that comes to the end of our class. Any questions? Did you learn something?
Right on time, 9:30.
I know, like chop, chop. These people have to come back tomorrow.
Just one question I have, Cornelia, regarding the final essay submission. Is it on the case study, the scenario?
Yeah, on that scenario, okay. Yeah, that's it. So you're all gonna write the same thing. I will just blow my head off and reading all the same thing again and again. But it's good for also for comparison to see where you guys are. And I think it gives you enough time to figure it out and do your own research. I don't think it's a too difficult topic. I think it's I picked something that does have a lot of literature for you, that has a lot of easily accessible literature, so you don't have to go browsing around like a mad person looking for where you are supposed to be. Yes, tomorrow 10:30 Toronto time. So just please be cognizant of the time that you need to present. There is people behind you, and if we start pushing each other, it just creates a lot of chaos, okay? Yeah, so these couple of last lectures are very, very heavy, and next 3 lectures are going to be, I'm just packing all the information that's going to be on your CIC exam. And I know it's a lot, but I want you to have an opportunity to refer back when you need it. So see you tomorrow, guys.